Welcome to Talking Type 1 Diabetes, a podcast series for healthcare providers who manage or treat type 1 diabetes, or those who just want to learn more about this life-changing progressive disease. Each episode features conversations between leading experts in the fields of endocrinology, primary care, and diabetes care. This episode highlights the value of early T1D detection for better preparation, education, and support, potentially reducing complications. You will hear from Dr. Jason Baker, a renowned endocrinologist and assistant professor of medicine at Weill Cornell Medical College in New York. Living with type 1 diabetes himself, he founded Marjorie's Fund, a nonprofit dedicated to improving diabetes care globally. And Dr. Amy Burton, a distinguished pediatric endocrinologist based in Plano, Texas. Dr. Burton is affiliated with Texas Health Presbyterian Hospital Plano and Texas Health Presbyterian Hospital Denton. Dr. Baker and Dr. Burton are being compensated by Sanofi for this podcast episode. TZIELD is a CD3-directed antibody indicated to delay the onset of stage 3 type 1 diabetes, T1D, in adults and pediatric patients aged 8 years and older with stage 2 T1D. Please see important safety information on screen and additional important safety information and full prescribing information provided at the end of this episode. Let's begin by hearing our experts' insights on the importance of early T1D screening and diagnosis.
So, I'm an adult endocrinologist, and I think that things might be slightly different on the adult side when it comes to autoimmune diabetes, to type 1 diabetes diagnosis and early diagnosis. But I think that there are still a lot of common themes between the pediatric side and the adult side. When it comes to progressing from stage 2 type 1 diabetes into stage 3, it can be a really rocky road for some people. And unfortunately, most of the time, people don't even know that they were in stage 2 before they were diagnosed with stage 3. And when you land at a place of stage 3, in a place of hyperglycemia, all too commonly diabetic ketoacidosis, it's really a traumatic event. So anything that we can do to prepare people mentally to more elegantly transition, but to help them to more smoothly transition into stage 3 type 1 diabetes, it will help put them on a much better trajectory for self-care for the rest of their life living with diabetes. I think that having people be aware earlier on helps them to form a support network. It helps them to start to look at their lifestyle and some of the changes that they might start to need to make to prepare living for a more progressed stage of type 1 diabetes, and mentally prepare from a psychological standpoint so that they don't go through that shock and that plunge, that quick plunge into living with type 1 diabetes that can really, really be a traumatic event, as I mentioned, for many people. It is essential that people go into knowing that they're not alone and go into stage 3 also having hope and being armed with as much of information as they possibly can. I know you guys deal with a heck of a lot more than the patient. You know, you're dealing with parents. What's your experience on the pediatric side with this?
Right. I echo a lot of your thoughts, and was thinking the same thing. I think before we've started to make a push to screen, most of our patients didn't even know that they were at risk for type 1 diabetes. So, I would say this conversation of the stages of diabetes has really just come up over the last few years. So, when I think of, I've been an endocrinologist for 18 years, and I think about, how I started off and how I would first meet a new onset type 1, it would be in the hospital.
Always,
so that is their first memory of me, and it's not usually positive because I'm walking into the hospital to tell their sick child, who's usually in the ICU, that, that their child has a new onset of, type 1 diabetes. The majority of these families don't even have type 1 diabetes, on their radar. While we are pushing to screen more first degree relatives, many people, do not have affected relatives. So I think, exactly what you were saying, the shock to their system, the fact that, we tend to have a big peak in the summertime. And my theory on that of new onsets is that, you actually are with your kid a lot more during the summer, and you notice, man, they're going to the restroom a lot, they're losing weight, or they may have a cross-country trip, they're in the car, and they have to stop more often to go to the restroom. And I've actually had a few families just this summer get diagnosed in areas that are not their home because they were on vacation. Mm-hmm. So you imagine being in a city that's not your home, you find out your child has a diagnosis, you're in a hospital in a city that you're not familiar with. You're given this information, and exactly what you said, we are trying to teach them everything they need to know about diabetic care in a 2-day hospitalization. And they don't remember most of it. So it really does not set them up for success. Have you found in your experience, now that we are, trying to screen more people, have you found in your experience that of course I see the whole family often, but when you have a patient with type 1 and maybe you're encouraging them to screen their children or, their siblings or whatever it might be, do you find that they're open to it? Like, what have you found is the attitudes that you've had towards screening?
It's really interesting you say that, because that is something that's absolutely changed in the last really less than 3 years of my practice, in terms of talking beyond the patient in front of me as it relates to type 1 diabetes, but in a more tangible way. So it's absolutely part of the conversation I have when people come in to see me for diabetes. If they have kids, I talk to them about screening their kids. If they have siblings, I talk to them about screening their siblings. In addition to taking the usual family history. But I have a varied response to it. There is a heck of a lot of fear for screening kids, for example. So I find that, when I have that conversation, and many times, how it is in healthcare, we may have a minute and a half with people. Hopefully a little bit more than that, but sometimes it feels that way. So I refer people to various websites and try to compile together. And I know you have something that you've compiled that you hand out to people too, that gives them an idea as to how to screen and what that screening might mean and might look like. I think that having an initial discussion will always be followed up with another discussion at another visit. I find some people are totally open to it, but many people are still fearful until I start to tell them, well, actually, there might be something that potentially could be done to slow down that process.
The narrative has changed over the last few years. Before they were offered, with different research studies such as TrialNet or things like that, these families were offered screening, but they would ask me, let's just say 10 or 15 years ago, they would ask me, what do you think, Dr. Burton, should I screen my children or not? And back then I would say, well, it depends on, are you the type of mom that can sleep at night if you know your child has positive antibodies? So my discussion on how I approach these families is much different. I think a lot of families, because of the previous discussions they've had with me or other providers, they kind of just feel like, well, we're just destined to get, if we're destined to get type 1 and go on insulin, then we are. I would rather not worry about it. That's how people used to kind of look at it and maybe not get their children screened. Now that we know that, well, I tell them we have some options to delay progression. There's a lot more research being done. You might be able to be in trials, things such as that nature. I think they are open to it. But then what's interesting for me, because usually kids with siblings, is I think the parents have a little guilt that they couldn't do it for the first child. And they feel like, oh, what if, the younger sister is able to, not go on insulin or prevent their progression. I think there's some mixed feelings about it. So
Yeah,
it's complex,
I can,
you know?
I completely agree. And that's putting rubber to the road with the whole screening thing, right?
Yes.
I mean, you know, I have also a fair number of people who screen positive, for example, for one antibody.
Yes.
And I think that, you know, there's a question mark. What does that mean? I think that we tend to think it means that there's something autoimmune happening. But even when somebody has two autoantibodies, and I say this, you know, in so many parts of medicine within and outside of type 1 diabetes, I mean, sometimes we just don't know. Nobody can say 100% that something's going to happen. And I don't know, on some level, I feel like that helps to prepare them for kind of living with some of the uncertainties of what it takes to live, for example, with type 1 diabetes in general. Sometimes we just don't know, and we have to be able to realize we are not always in the control that we might want to be in general. And so there's an acceptance and kind of a, oh gosh, I hate to even use this word as though it's acceptable, but like introducing the trauma in a little bit smaller of a way instead of throwing it at somebody, you know, having a chance to kind of digest smaller bits so that the memory is not quite as traumatic. I mean, that's I think overall the benefit of screening, but there is going to be trauma in that. I had somebody the other day who screened positive for one autoantibody and was crying, you know,
Yes.
and had a family member with type 1. And there's a chance that might progress. And there was a long conversation about what that means and what that might not mean. And ultimately trying to steer people into realizing that, you know, while there's nothing that's guaranteed, it's better to have that information. And following up those conversations again and again, that initial chat you have with those family members who may have that guilt, right?
Right.
You know, I'm sure that you do this too, but I talk to a lot of them about saying, well, you know, maybe, you know, if you're having trouble kind of living with this and handling this, think about expanding your support structure, right? If you don't have
Right.
a family member or friends, you know, maybe you need to have a therapist you talk to or talk to your therapist about this topic. You know, trying to know when to not grab guilt, right?
Right.
And use the energies to fight and prepare rather than live in guilt. But or fear. But it's tough. I mean, you know, we all talk about screen, but there's a lot of follow-up that needs to happen to do it in the right way. I totally agree with you.
Thank you for sharing your experience regarding patient and HCP reactions to T1D screening. Next, we'll discuss available resources and support groups to help patients navigate their condition and new diagnosis.
If somebody feels that they need extra support around the topic of, you know, living with the specter of stage 3 type 1 diabetes, having been screened in, like what are some of the support networks that you might plug them into?
We have a JDRF here that has like family support groups. So the Juvenile Diabetes Foundation, Research Foundation. We also have, there's a large camp here called Camp Sweeney for children with type 1. And they have like monthly, every month or two, they'll have social events for the children. And then the parents can meet up as well. So
Yep.
I think that's helpful. I have a few patients in my clinic who have, whose moms have always voiced, hey, they have their own support groups here in the DFW area, in the Dallas-Fort Worth area. And so they're always open to me sending them, you know, new families or people who have questions, because I have a few families who have 4 or 5 diabetics in one family. Yeah. And those moms are very proactive, and they really help some of my other new, you know, families to digest some of this, because they've gone through every spectrum of, you know, kids not having it to developing it, and now having, you know, insulin, you know, being on insulin pump, all of those things.
I'm always jealous of you pediatricians and the pediatric side, because I feel like, you know, on the adult side, we get the short end of the stick with those support. You know, we don't have camps. I mean, we there are some, but it's just not as much of an emphasis. It's kind of like you're on your own and you have to find your communities. So, you know, on the adult side, like you, I mean, Breakthrough T1D is a good organization beyond type 1. Any social network, there's various Facebook sites bringing type 1s together. I always try to, if I have a new type 1 who comes in and sees me, and I feel like, many of them might be living away from home, and they're, in a new city, and maybe they're with a new job and they're already having other stressors. Making sure that, asking, are you comfortable with me putting you in touch with some other people, identifying some peer educators who might be able to help that person. There are meetings that happen that healthcare providers are not invited to, which I think is great.
Thanks for providing our patients with essential resources to help them better understand and manage their condition. Now, let's hear from our experts on how screening can reduce T1D misdiagnosis and improve patient care.
So one question I did have for you, because it is changing my practice a little bit now that we are, being very proactive about screening, is how about screening those who look, who we might have considered as a classic type 2 patient? So, insulin resistant, slightly overweight, maybe, Asian, Native American, African American, those types. I know in my practice now, I get a lot of pre-diabetic kids that come see me that are slightly overweight, going through puberty. And I now screen all of them for, antibodies. Whereas in the past, I would have thought, oh, they're Indian, insulin resistant, going through puberty. It's probably, insulin resistance. So I was just wondering, we were talking about the benefits of screening early. I think also it helps prevent misdiagnosis.
Yeah, absolutely. I think if somebody doesn't smell like a typical type 2, I will screen them, number one. So, again, if they're that kind of leaner type 2, doesn't quite fit that picture. But I think at this point, we probably have to do some targeted screening, with people who have other autoimmune conditions or family history, if you're talking population-wide.
Right.
But my threshold for throwing in autoantibodies, if somebody sees me and isn't responding in the way that I think, or if I have any thought that they have some level of greater risk for autoimmunity, be it their body habitus or be it other autoimmune conditions, I will absolutely screen them for the autoantibodies. And I tend to just do all 5 if I really feel that they're at risk. And I'll screen again if I feel like they're negative and I'm surprised by that negativity. I agree that it is important to classify people correctly, because you don't want to do anything right that can accelerate beta cell loss. You want everybody to hold on to that C-peptide, that beta cell health as long as possible. I mean, we see study after study that says, hey, those who have their own insulin production as evidenced by C-peptide, guess what? They do better. They have less complications. So anything that we can do to hold on to that, I think, is key. Another thing, I screen all of my type 1s for C-peptide to see if they still make some, because I think that it is a good thing, and I follow it. And I think that having a conversation with how to hold on to it is also important to have, even if they already have a diagnosis of type 1. So anything we can do to prolong the C-peptide is really important. In somebody who on the pediatric side, like from a tool perspective, a question I have for you is, are you guys using a lot of CGMs to help people to test out foods and personalize diets in order to, better and potentially stress out their beta cells a little bit less through avoiding hyperglycemia? I mean, how are you using CGMs, for example, in where does that fit in for you in this whole screening process?
Yes. So when I screen a child and they have, I would say, 2 positive antibodies and are normoglycemic, I often will, write a prescription for CGM. I have CGM samples here. So I give them a CGM, and then I often will also send them home with, a CGM, and I can write a prescription for one because they technically have type 1 diabetes. So I've had no issues getting coverage, like coverage issues for getting a CGM covered. Okay, so I'll write them a CGM, and I'll have them, especially even for my purposes, I'll have them wear it. I also think it gives them very good feedback because I give them some dietary advice. I have a dietitian in my office So I give them some dietary advice of things to avoid, mostly like sugary beverages and, those types of things. So we do, once they have been diagnosed with stage 2, even stage 1, I should say, with positive antibodies, we do a little bit of education. So kind of what, like you were saying, we're giving them piecemeal, piece by piece, a little bit of like introduction into how to count carbs, how to, glycemic index of foods. Because I just think when you're thrown into stage 3, it's very hard it's like drinking out of a fire hose.
Yeah. And I agree with the for everyone standpoint.
Yes.
I know we're talking about type 1 diabetes today, but on the adult side, I tell you, CGMs have been revolutionary for pre-diabetes, weight loss, empowering people in various flavors of conditions, right? But, when I was diagnosed, it was kind of I'll never forget the nutritional advice I got. And granted, this was in the 1930s. No, I'm just kidding. But this was a while ago, right? But the nutritional advice I was given was kind of a one-size-fits-all thing. And I think, which didn't fit for me at the time, right? And I'm somebody who grew up in North America and didn't, and had a fairly traditional diet for this region. But, for somebody, I think that the CGMs have allowed people to work within their own preferences and their cultures and the types of foods which may be available to them to have, to better personalize it. So they don't feel like they're in mourning from the beginning about having to just be a draconian and give up things, right? But yet helping them to ease into it, again, with a little more grace and less trauma. So I agree. I think that those are such valuable tools in helping people to become more educated. And also, I try to help them to understand what those spikes on glucose sensors are and what's happening in their body when those spikes happen. And that, the fact that if they're not yet on insulin and they're in stage 2, for example, when they have a spike, they're stressing out their beta cells to have to work a little bit harder. And the harder the beta cells have to work, hypothetically, the quicker they might tire out. And so to try to help them to understand, to be proactive about holding on to their beta cells, to kind of cater their diet toward having more gentle ups and downs, getting away from the Alps and more to the Catskills. Sorry, I'm very East Coast centric here. But just to try to help to empower them for dietary changes and also lifestyle changes.
We appreciate your insights on who to screen and how to leverage available tools to mitigate the risk of T1D misdiagnosis. Let's conclude our conversation with a discussion around TZIELD and how our experts discuss TZIELD treatment with patients.
I was just curious, now that we have the ability to slow progression with TZIELD, how have your patients been, those who are in stage 2, as far as, when you offer them, the option of treatment with TZIELD? How have they been as far as, of course, we are very excited about it. But I was just wondering how your adult patients feel and also other providers that we're trying to educate.
Mm-hmm. Yeah, it's interesting. I mean, I think now that TZIELD's been out for, frankly, almost 3 years, it's not too surprising that there's still a lot of people that don't understand it or even know about it. And so I think that that's changing, but I think that the way that I bring it up with patients who I think are candidates for it is to tell them that there's no guarantee to what their response may be. And that I don't know if they're going to be one of those patients who are really amazing responders who have had good responses well beyond 5 years, or if there'll be somebody who progressed still to stage 3 not too long after the treatment itself, because there is variability in terms of how people may respond. I'll try to present to them the information as best I know it about what the odds are and the likelihood are of them getting treated, but I'll plant a seed and have a discussion And then many times I arm them with information about it. And then over the next couple of visits, we'll talk about, assuming this isn't a new diagnosis and rapidly evolving. And look, when it comes to side effects, I always very clearly go over all the potential issues. And I tell them, look, I would rather do too much testing than too little testing during the actual treatment, both before and after. And so, we've all tried to come up with these protocols about how to follow people before, during, and after treatment. And there's no perfect consensus. I can speak to what I do, which is, making abundantly sure that all of the necessary blood tests, liver, kidney function, white blood cell counts, certain infectious parameters are all normal before treatment. And I like to test a lot during treatment. So every 2 days during the entire treatment, Amy, I'll get the labs. And this, at least a CBC and a CMP, to make sure that liver function's okay, and to make sure that their white blood cell count and lymphocyte count goes down and then recovers within the right amount of time. And then I'll follow them weekly for the first month after treatment with labs, and then go back to kind of a usually scheduled program. And on top of that, of course, I want to assess what I think as best I can, their own insulin production levels. So I'll be following their C-peptide levels and seeing if there's any sort of course, maintenance of that over time, but potentially even an enhancement of that. So, and people do have side effects from this. I mean, the way that the drug works is it does cause a release of cytokines in a person's system. So they're gonna have some side effects. Some people are worse than others. But there's a great way of mitigating those with pre-medications, right? So just like you would if you had an allergy to, contrast dyes if you were getting a radiology study, you take pre-medications with this under the assumption that you're likely to have some sort of reactions. But in my experience, most people's reactions are very mild, and so it's very well tolerated. And if they do have something more severe, stop the treatment, but I feel like when people hear that it's very well tolerated and that actually immunomodulation is not new to endocrinology in terms of new to all aspects of medicine. I should say it's maybe newer to endocrinologists, but it's certainly not newer to other parts of medicine, right? So, we tend to be very self-focused as endocrinologists to be like, oh, this is the only part of medicine here. And we're not aware that, hey, guess what? A lot of this immunomodulation has been happening for years in other fields, gastroenterology, rheumatology, you name it. So we are kind of late to the game with this, but there's a lot of data to show safety. And I feel like when I have those kind of conversations with patients, those very real conversations, I feel like on the adult side, they respond pretty well. What about the kid side, though? Like, how do you handle that with a worried parent, and how much do you involve the child in the conversation?
Right. So I usually involve the child and the parent. I'm usually talking mostly to the parent. My last 2 infusions have been teenagers, so they have been, involved. One was one without any family history, and one was a sibling of a type 1. So I think the one who had a sibling with a type 1 was all in because she saw what her sister went through. And she was about to go to college. So to her, this was a chance of possibly going to college without, needing insulin. And so I think some of my parents that come in already have done their research, have heard that, TZIELD came out and were gung-ho. Some of the families, I just caught on screening, and type 1 wasn't even in their, just playbook,
thought process.
Process. So I think the ones who were not as familiar with type 1, I had to spend some time on to convince. But like you said, with pediatrics, they tend to progress much faster. So I didn't have as much time with them, but I would just have them come back in every 2 weeks, have them wear a CGM. They would see that the sugars were starting to go up with certain types of food. And I think having that data and then building that trust and rapport with that family, the one family that I had to take a little bit longer to, get them to build trust, they didn't have the best trust of the medical system. And I do think, as physicians, we are seeing, I would say in the last 5 years or so, many people are very not trusting of new, FDA approved medications, vaccines, whatever it might be. So I do think that we are having to probably work a little bit harder to dispel any misinformation, and then also get them to trust, the data that we have. So I think I end up having to spend some time giving them information about the studies. I think it's nice that TZIELD even has like parent advocates.
Yeah, I was going to say people would already gotten it, right?
Well. Yeah. So they can speak to other, people that have gone through the process. So I think that's also helpful. And so I think most families are actually pretty open eventually once they understand everything and realize, like you said, safety, it's been very safe. I've had very few side effects, usually a rash and, kind of flu-like symptoms. So everyone's done great. So that is also helpful, like you said, that we've had several infusions. So we have that data to show them, hey, look, I have these patients that have had them. What I find interesting, exactly what you said and touched on, was my families are pretty open, but sometimes I think some of the providers have not been as open as I expected. I have been, very excited about this since it came out. And I would say when I've spoken to other colleagues, I just have a small private practice here in Dallas, but there are 2 large groups here in the DFW area, and there's multiple endocrinologists. And when I speak to others, some of them are just like, well, I don't know if I want to, use a biologic on a patient, because us as endocrinologists are not used to this class of medication,
right,
like you said.
Right.
And then they would say things like, I don't know if 3 years is really worth it. And those things would just shock me, because kind of going back to what we were saying, the benefits that you can get, even if you were off of insulin for 3 years, like the one girl I sent off to college, she's about to start her junior year of college, still off of all medication. She wears a CGM, and she had her TZIELD infusion her senior year of high school. And I think the fact that she's able to rush, be an architecture, major, not have to worry about middle of the night hypoglycemia, her insulin supplies, and from my standpoint, even for as a mother myself, to be able to sleep at night and have a kid that's in another city from me, and not worry about, the CGM alarms, insulin, running out, pump breaking failure, those types of things. I just don't think you can put a price on that.
Thank you to Dr. Baker and Dr. Burton for sharing your thoughts on the value of identifying the early stages of T1D. There is currently no evidence to suggest that TZIELD will have any effect on burden of disease, outcomes, or life expectancy. Our experts' guidance will surely help our audience better support their patients through the T1D journey. Thank you for listening to Talking Type 1 Diabetes, a podcast series for healthcare providers who manage or treat type 1 diabetes. Be on the lookout for other episodes of the Talking T1D podcast, available on TZIELD.hcp.com and YouTube. For more information regarding TZIELD, visit our website at TZIELDHCP.com. Please be aware of the TZIELD indication and important safety information, indication and usage. TZIELD is a CD3-directed antibody indicated to delay the onset of stage 3 type 1 diabetes in adults and pediatric patients aged 8 years and older with stage 2 type 1 diabetes. Warnings and precautions. Cytokine release syndrome, or CRS. CRS occurred in TZIELD-treated patients during the treatment period and through 28 days after the last drug administration. Prior to TZIELD treatment, pre-medicate with antipyretics, antihistamines, and/or antiemetics, and treat similarly if symptoms occur during treatment. If severe CRS develops, consider pausing dosing for 1 to 2 days and administering the remaining doses to complete the full 14-day course on consecutive days. Or discontinue treatment. Monitor liver enzymes during treatment. Discontinue TZIELD treatment in patients who develop elevated alanine aminotransferase or aspartate aminotransferase more than 5 times the upper limit of normal, or ULN, or bilirubin more than 3 times ULN. Serious infections. Use of TZIELD is not recommended in patients with active serious infection or chronic infection other than localized skin infections. Monitor patients for signs and symptoms of infection during and after TZIELD administration. If serious infection develops, treat appropriately and discontinue TZIELD. Lymphopenia. Lymphopenia occurred in most TZIELD-treated patients. For most patients, lymphocyte levels began to recover after the 5th day of treatment and returned to pre-treatment values within 2 weeks after treatment completion and without dose interruption. Monitor white blood cell counts during the treatment period. If prolonged severe lymphopenia develops, less than 500 cells per microliter lasting 1 week or longer, discontinue TZIELD. Hypersensitivity reactions. Acute hypersensitivity reactions including serum sickness, angioedema, urticaria, rash, vomiting, and bronchospasm occurred in TZIELD-treated patients. If severe hypersensitivity reactions occur, discontinue TZIELD and treat promptly. Vaccinations. The safety of immunization with live attenuated, live vaccines with TZIELD-treated patients has not been studied. TZIELD may interfere with immune response to vaccination and decrease vaccine efficacy. Administer all age-appropriate vaccinations prior to starting TZIELD. Administer live vaccines at least 8 weeks prior to treatment. Live vaccines are not recommended during treatment or up to 52 weeks after treatment. Administer inactivated, killed vaccines or mRNA vaccines at least 2 weeks prior to treatment. Inactivated vaccines are not recommended during treatment or 6 weeks after completion of treatment. Adverse reactions. Most common adverse reactions, more than 10%, were lymphopenia, rash, leukopenia, and headache. Use in specific populations. Pregnancy may cause fetal harm. Lactation. A lactating woman may consider pumping and discarding breast milk during and for 20 days after TZIELD administration.